Welcome to our August virtual chat with an expert. Our expert tonight is Dr. Priya Tatachar. She is on our medical advisory council and she's on staff at the Lurie Children's Hospital in Chicago. And she is coming tonight to talk about a really important and very, very timely topic, which is rescue medications and seizure management, and especially timely as kids are heading back to school. And I was just speaking with Dr. Tatachar just a few minutes ago, telling her all the number of calls I've been receiving this week alone, even just today, on how to handle the 3 FDA-approved rescue medications. So I am going to turn it over to her. She'll be sharing her screen. And if you have any questions, please feel free to ask them in the chat and we'll address all of the questions at the end. So welcome and thank you, Dr. Tatachar, for joining us.
Thank you, Aisha. Thanks for giving me this opportunity today to talk about this really important topic. I'm Priya Tatachar, and I work at Ann and Robert H. Lurie Children's Hospital. And just to start out, let's see, this is going to, okay. So just as an overview, we're just going to talk about seizure rescue. What is seizure first aid? A bit of definitions to understand what is status, what is the concept of rescue medications, why we give what we give, and if there is anything new that we're seeing in the field that I will share with you today. And then we'll have a forum for discussion after the talk, okay? So let's start out with a scenario. I'm sure most of you have been in this scenario at some point in your lives, right? You're at a birthday party, let's call it Chuck E. Cheese. There is a child that falls to the floor with a cry, starts to stiffen, and then goes into a generalized tonic-clonic seizure. So if you imagine that scenario, what generally happens, right? If you think about it in your mind, generally there is a stunned silence, and then there's just pandemonium, right? Someone's like, give him some water. That's not true. Someone says, put the spoon in his mouth, he's going to chew his tongue off. We've heard that a dozen times. No, that's not true and it will not happen. Okay, someone's going to say, let's hold him down. Just hold him down. He's shaking too much. It's going to calm him. Or we're going to embrace him. It's going to have him stop seizing. And that's not true. And since you've been in the scenario before, you know what to do. And since you have seen Epilepsy Foundation brochures, you remember what to do. Okay, so what do? You first assess the area, making sure that the child's not on anything that can injure them when they're having seizures. You clear the area if there is something that's going to injure the child. You cushion the head because when they're having a generalized tonic-clonic seizure, you don't want them to keep banging their head against something that's hard. Somebody is going to time the seizure, which is the one thing that I think people forget to do when it's a panic situation. And of course, if you have done this before or you know about this, you look at the patient, you make sure, is there a medic alert bracelet? Is the child wearing a bracelet, or is there a VNS magnet? Is there something identifiable in this child? And then when the seizure is over, you put the child in a recovery position, which is a lateral position, ensuring that the airway is open. And then the things that you never do, right? You never do is you don't restrain the child, you don't put things in their mouth, you don't give them things to smell, you don't try to feed them with water, ensuring that they don't essentially choke on anything at that point, because they've lost consciousness, they're not going to be aware of what you're doing to them. So now you decide you're going to be the person watching the time, right? It's been 4 minutes and 49 seconds. What do we do now? Someone's notified the parents, they're coming, they have the diazepam rectal, the management has contacted 911, EMS is on their way, the child breathing, it seems like he's still having a seizure, but he's breathing. So we go on to some definitions, right? What is status epilepticus? So the old definition was half an hour, okay, 30 minutes of continuous seizure activity, or 2 or more seizures back to back without recovery of consciousness between them. That has changed now. We've shortened the time. The current definition is 5 minutes of convulsive activity or 2 or more seizures without, coming back to consciousness in between. This is the more current and accepted definition now. Why does status occur, or what promotes a seizure, a regular seizure, to go into status? So essentially, we know that seizures typically are self-limited, typically, and usually stop between 2 and 3 minutes. The brain has inbuilt mechanisms to stop the seizure between 2 and 3 minutes. Now, if those inbuilt systems fail, the seizure continues on beyond 3 minutes and then beyond 5 minutes. Or once the seizure starts, it sets a downstream effect into motion that prevents the seizure from stopping by itself. If this situation occurs, then a seizure can go into a status. So essentially, it's the time duration of the event per se. Why is it such a big deal, right? Why are we so much about treat early, treat fast? It's because long-term consequences of status epilepticus, and we've known through a lot of studies now that a seizure that continues beyond a particular time, or typically a convulsive seizure that continues beyond a particular time, can cause neuronal injury. And the neuronal injury can be here like neuronal death, or alterations of neuronal networks, or essentially triggering the seizures to keep going on and on. And so, because of the variations of, and the fact that there are so many different types of seizures, the ILAE put in specific time periods for status epilepticus. 5 minutes for generalized tonic-clonic seizures. Now, previously, we used to call this a grand mal seizure. Okay, and in literature, it's still called grand mal seizure. If you look at old articles, it's essentially a convulsive seizure. It can be starting out as a partial seizure and then become a generalized tonic-clonic seizure, or it can be a primary generalized tonic-clonic seizure. But if this lasts more than 5 minutes, then the likelihood of it stopping by itself is very low. If it's a focal seizure, or a complex partial seizure as they used to be called, the time duration is 10 minutes, okay? It's just longer because it's coming from one focal part of the brain, and it's not generally dulling your consciousness to the extent of a generalized tonic-clonic seizure. Now, previously, they used to call these the petit mal or absence seizures, is a particular type of seizures that occurs in children. And usually they go into what we call as a non-convulsive status, which means they don't have all the shaking and the drama of a generalized tonic-clonic seizure, so they may be missed. So for these kind of seizures, the time duration is 10 to 15 minutes. And these are the periods for status epilepticus, so 5 minutes and 10 to 15 minutes. So let's go back to our child. Now, the parents came, they got rectal diazepam. He got the rectal diazepam at 5 minutes and 8 seconds. EMS comes in, they look at him, the seizures have stopped. His vital signs are stable, but of course the child is extremely drowsy. So the EMS then takes him over and said, we're gonna have him assessed in the emergency room. And I'm sure if this has not happened with your child, I'm sure you've witnessed this at some point. And so to kind of bring this all into perspective, status epilepticus is a seizure that occurs for a longer period of time than a normal seizure would for that particular child, and doesn't stop by itself. Okay, and it's about 5 minutes for a generalized convulsive seizure, and 10 minutes and 10 to 15 minutes for non-convulsive seizures. So because we spoke about what the damage it could do, we need to stop this as soon as we can. So when we talk about rescue medications, right, we use rescue medications, and that has to stop the seizure right away. If we give a medication to stop status epilepticus, it shouldn't take 30 minutes to start working. That defeats the purpose. So we need to get a rescue medication that acts quickly and can prevent a seizure from going into a prolonged or refractory status epilepticus when they kind of go on and on and on, and then you start having to use a lot of medication. So we want to prevent that. And we want to prevent the child from getting intubated because of status, right? So you want to give a medication that acts fast and stops the seizure. There's another group of seizures that we call as acute repetitive seizures or clusters of seizures. Now these could be short seizures, but they occur really quickly over a period of time. And these, in general terminology, are called clusters. Okay, these are clusters of seizures. To remember that clusters are very individual. Each child or each patient has a different, definition of cluster. It can be 3 in an hour, or it can be 3 in a day, or if a child has seizures, probably has 10 seizures a day, then the cluster for that child can have a different definition. So it's just very individual depending on the patient's baseline seizure frequency. So we spoke about this a little bit, right? What do we need? Why do we need to use rescue meds? So basically, we have to reduce the length of the seizure so it doesn't go on to a refractory status, and we have to decrease the possibility of this occurring again soon, right? So what would then happen is once this is stopped, the chances of adding more medications, chances of going to the emergency room, chances of admission to the hospital, and overall healthcare costs definitely decrease. So we need a medication that we need to use that kind of helps us in all of these scenarios. So which one should we use? There's I think many different types of epilepsies and many different causes for epilepsy. We need to use a medication that can be used for all of these, whether they have a underlying cause that is different from another patient. If they are having a seizure, we need to use a common medication that is easily available, and easily administrable by people who are not in the medical field. It should act immediately, right? If you give it, it should act and it should stop the seizure. It should be cost effective. It shouldn't be super expensive to buy this medication. It should be used you can use it safely in a child and you can use it safely in an adult. So it should basically have that's our ideal drug, right? Now, again, we spoke about types of seizures. Now, a patient can have a seizure once a month or can have 3 times a month. We need to have a medication that lasts and you don't have to keep refilling, every month or every 15 days. So it should have a long shelf life and should be easily transportable. Can be kept in school, can be kept on person, can be kept in the car. So it should be easily transportable. So let's find if we have ideal rescue drug. These are the different ways we can get the medication into somebody. There are multiple different ways of getting medications into a person, and we've explored pretty much all of the different medications in giving rescue medications for epilepsy. And we also have to take into account many different things when we are searching for the ideal drug. We looked at the drug. Now let's look at the patient. So on the patient side, we need to make sure that the patient does not have comorbidities, that we cannot use this medication. The patient is not pregnant or this medication should be used safely in pregnancy. We have to also make sure that, there's different characteristics on the patient side, like lipid solubility, blood flow, and what is the type of administration we're doing would depend on the medication that we choose or the ideal medication that we do. So most of the times we say IV is the best way to get the medication in a patient, right? But the problem with IV medication is that you cannot do it at home and you cannot do it in school. It has to be done by a trained professional. So it takes a lot more, expertise to do IV access. So we have to find something which is not 100%, but close enough to IV. The medications that we always use and the medications that are first line in acute seizure medication rescue is benzodiazepines. There are a group of medications, benzodiazepines, and we'll go over a few. We use a lot of these for epilepsy. They work on the GABA receptor. So what is GABA? So gamma aminobutyric acid is the most common neurotransmitter that usually causes the inhibitory signals in the brain. Now, GABA is it's pretty common. It's found in the cerebral cortex. It's found in the limbic system. It's also found in the spinal cord. But the most important areas that we are concerned with is the cerebral cortex. What does GABA do? It kind of is a fuse. It kind of puts a fuse on the nerves, right? So it kind of stops them from being super excitable. And how does it do that? It releases calcium. It releases chloride channel ions into and the chloride ions kind of, by electrical negativity, kind of stop the excitability of neurons. So the GABA, what it does is increases the frequency of opening of the chloride channels. And because of that, it can act pretty quickly to stop seizures. Now, there are different types of benzodiazepines. There's also different times of benzodiazepine action. And we've used a lot of benzodiazepines, and it is regarded as the gold standard for a first-line seizure management. Now, if you've seen this algorithm, this is the algorithm we use for treating status epilepticus. Let's say you're outside non-emergency or a non-healthcare setting. This patient has a known history of epilepsy. What is the first thing that we look for is, does this patient have a home rescue medication on person? If that's the case, we go ahead and use that. And again, seizure onset would be depending on that person's seizure action plan. If the seizure action plan states seizure greater than 5 minutes, then yes, time the seizure greater than 5 minutes, go ahead and give the home rescue medication. Now, that's if the patient has a VNS, that's another good option to swipe the VNS. Somebody is calling EMS at this time. But when the EMS comes in, they will check to see if the seizure is ongoing. Now, what they will try to do if the seizure is ongoing, they will try an attempt of getting IV. If they get an IV, they will go ahead and give IV lorazepam, which is another benzodiazepine. Now, if they don't get an IV access, they do not waste time trying to get one in the field. So then we can go ahead and do what we call as intramuscular. So just a jab in the eye of another benzodiazepine called midazolam. Or if they're unable to do either, they just go ahead and do a second dose of rectal diastat. And we will talk about the newly approved intranasal diazepam in a future slide. So take home point, number one line of medication treatment for acute seizure treatment is benzodiazepines. This is to prevent status epilepticus. Many of you may know that there are different types of benzodiazepines that are in the market. Many of them have been used for epilepsy. Not all of them are used as acute seizure medications. Some of them we use for chronic seizure medication as in a long-term medication, but you can see that most of them that I've circled here are used for acute seizure treatment. In 2018, they came up with this Cochrane review that included different randomized control trials. Excuse me. And this was before we had the approval for the two newer medications that we have now. Excuse me. And this was undertaken, as a way to find out which is the best medication for convulsive status epilepticus treatment. Again, they found that intranasal anticonvulsants and buccal, which is just putting it in the side of your cheek, had a pretty good efficacy, even comparative to intravenous medications. And so right now, this is not yet available still. Buccal midazolam or rectal diazepam at that point were touted as the first line medications. And again, buccal midazolam is not available here, but rectal diazepam has been the only medication that was around here for many, many years. So rectal diazepam, 1998 came into play, started having a lot of articles that showed that they're very effective in the treatment of cessation of acute repetitive seizures. This was a 1998 study which showed definitely a single dose of rectal diastat was efficacious than placebo in treating seizures, acute repetitive seizures or status. So they tried rectal diazepam versus placebo. And remember, this was the only seizure medication FDA approved for the treatment of status epilepticus from that time until 2019. So for a very, very long time, this was the only medication. And it is a great medication. It is a great rescue treatment. And we base it on the weight of the child and the age. And usually if a child is having seizures that seem to be going on, let's say this child is having a seizure that's lasting about 3 minutes, and you have the rescue medication, I usually tell my patients or my moms who carry this in their purse to assume the mom ninja position. You put your child on the lateral side, to the side. You straddle the child, between the two legs. Get your the diazepam ready to go. Pull down the pants and put it in. If you haven't done it the first time, you may have it squirt all over, but you will get better with time. And there are videos and instructions on how to do rectal administration. And most of the times, if you can ask your clinician or your healthcare provider, they will have demonstration by the nurses when you visit the clinic if you are using it for the first time. So it's important to know how to use the medication. Okay, and then most clinicians in the United States are still comfortable with rectal diazepam. Most often, right up until FDA approval, a lot of clinicians were using the intranasal midazolam off-label. I'm not sure if many of you have used the syringe and the mucosal automator device that was being used up until the official FDA approval recently. And many times, if a child's having acute repetitive seizures because of an illness or because of some underlying, instigating issue, then your provider can start a clonazepam rescue, which we usually do. It's the oral disintegrating tablet. You place it under the tongue, and it disintegrates. You use that as a bridge to get seizure control. So that's clonazepam. So this was also replicated in the study that was done in 2019. And then I was just talking about cost effectiveness. We don't have the buccal midazolam, and I think that's the most exciting thing I'm waiting to come into the market. However, the nasal lorazepam, and if not IV, then intramuscular midazolam and rectal diazepam, they're basically about the same in terms of cost effectiveness, but the most cost effective medication was buccal midazolam, and then the next thing was intranasal midazolam. Okay, so up until 2019, right, we only had rectal diastat. It's a great medication, don't get me wrong, but there is some, having epilepsy in itself is it's difficult when you are a person with epilepsy to deal with epilepsy itself. And on top of that, to have a rescue medication given in the butt, can be very stigmatizing. And this was, I just wanted to share a note from a parent of a child who had developmental disabilities. And she had episodes of status in school. She was in a special school, and during recess had to be given rectal diazepam. And when she came to, and she found everybody was looking at her, she refused to go to school after that and just did not want to be seen by her peers. So at this point, the parent said, is there any other way that we can do this rescue medication? Because, it just took a toll on that child's psyche. So let's explore if there were other routes. Okay, so we said there's different routes that we could do. We said intranasal, we said buccal, sublingual, subcutaneous, intramuscular. So definitely there's a lot of different options. And so we have our first line medications, the diazepams, the midazolam, and the lorazepam. Let's see if we can plug them in different routes to be given with the same efficacy as the rectal diazepam. These are just the doses. And if you guys remember, this was what we came up with before FDA approval. So we said, why not? We had tried diazepam intensol in infants, where we would place a drop of diazepam on the cheek, and it seemed to work. So if that works, can we try something similar, not rectal, but intranasal or buccal? So intranasal midazolam, this is before the one we have right now with the mucosal automated device. We were using this off-label with really good effect. The problem with that is that it was not FDA approved, so it was pretty much out of pocket. B, it wasn't FDA approved, so many schools refused to carry that or administer that. And so many schools said we're only going to do rectal diazepam no matter what because this is not FDA approved. So that was an issue. And then of course availability. So it wasn't available universally. So then, drum roll, we had the first rescue medication in 20 years. This was nasalam or midazolam nasal spray. So the same exact thing that we were doing, with the mucosal automator device, they came up with a much more elegant and a much more portable way of doing this. So if you have seen it, and I have a sample I could show you, this is supplied as a single spray unit. It's a very small, easily portable. It comes as like a little spray that you need to insert in the nose and put the plunger. Of course, we tailor how much that we need to give based on the patient's age and based on the weight of the child. This, though, is also very patient dependent, but it is recommended that it should be treated for no more than one episode every 3 days. Again, that's a blanket, but we have to individualize it per child. Okay, so what are the adverse effects? So for most benzodiazepines, the number one adverse effect is sedation. So, they go to sleep after the seizure, from the seizure, and they go to sleep after giving the diazepam as well. Now, second thing that we always worry about is it can cause a decrease in respiratory drive. So they have slowing of the respirations, and maybe at that point we worry about decrease in oxygen saturation, right? So that's one thing that we always say, if you look at the child turning blue, have EMS come in and check for breathing. And then of course there is an amount, it's used as an amnestic, right? So then benzodiazepines do not decrease pain, but they can cause forgetfulness of that incident. So they may have a little bit of a loss of memory of that particular event where it was given. And of course, with the nasal sprays, there's also burning sensation that has been reported by children. Again, in patients who have glaucoma or a family history of glaucoma, please make sure you let your doctors know, because it can cause an increase in the intraocular pressure. Again, all anti-seizure medications have a warning of suicidal thoughts or suicidal behavior. And that is because they all work on neurotransmitters on the brain and the imbalance of neurotransmitters. But it is a warning. It is not translate into real life in most of our patients because of the way we give our medications. It's not a sustain, it's used only as a rescue at this point. So this is Nasalam, and this is, if you look at the package insert, it comes again with instructions. Again, there is videos, there are patient handouts. One thing I would say is, if you get your Nasalam, do not try a test dose because you will lose a dose. If you need to test out or get the feel of how it works, talk to your provider, and the nurses will have a device that you can use for training. Okay, so make sure if you really want to get the feel of it, if you're very worried that you won't do it right the first time, talk to your doctor and the nurses, and so you can work with their sample to get the feel of it. Okay, um, it's a very easy administration. It comes as a single dose packet here, 1 dose per unit. You can hold the spray. It's let me see if I can. I don't know if you can see me, but here, this is what it looks like. It's very tiny. Okay, and this is approved for over 12. Okay, and you put this, essentially this is where the medicine is going to come out from. This is the plunger, and then you essentially press the plunger so it goes into the nose. Okay, so that's how you use Nasalam. Similar to Valtoco, the same kind of administration. Now, rectal diazepam was so good. Intranasal midazolam was now gaining a lot of ground in popularity. So diazepam said, why don't we try nasal and see how it works, right? Actually, it works pretty well. So now we have intranasal diazepam, or Valtoco. Valtoco just, I think, got approved last year, and it's approved for over 6 years of age. Okay, again, based on weight, we have different doses. Again, same exact mode of delivery. It's pretty similar to the way that Nasalam looks. Initially, we had a few issues with Valtoco. They had a very short like a shelf life. Some of the initial doses would expire within 3 years, but 3 months. But things have gotten better, and if you've had Valtoco that has expired, if you reach out to them, reach out to the manufacturers, they will send you an unexpired, newer version. Okay, so it's definitely a very, very good choice, a very safe and very effective way of terminating acute seizures. So we got all of that in the market, and then they went back and looked at safety studies after putting this in the market for at least for a year and a half now. And this is just, I don't think it's out yet, but this is ahead of publishing. The large safety trial that was done for intranasal diazepam, and it's definitely as effective in terminating seizures as rectal diazepam, because that was their standard. And again, most common adverse effects with intranasal diazepam was nasal burning, or a feeling of an discomfort in the nose. Some kids had bleeding or epistaxis, and a lot of patients complained of headache after the use of, but this was a self-limited headache. Okay, so other than that, it was quite effective in terminating seizure clusters. Now, this is a very fascinating way of delivering rescue medications. I talk about it because it's not yet on the market, but there was a study done in New York, and it's intrapulmonary. It's like if you know somebody who has asthma and who takes an inhalation, it's something similar to that. It's something similar to delivering the benzodiazepine right into your lungs. Now, how does that work? It's a very interesting system. It's called the staccato system. So it has a stainless steel kind of plate. There is a desiccated and dried powder, essentially snorting. It's kind of dried as a thin film on top of the stainless steel plate. And with the vaporization from your breath, the lung kind of, the medication sublimates and then enters your lungs. This was used in a small cohort in patients with photosensitive epilepsy. It is still not FDA approved and out, it's still in trials. So it seems like a promising way of delivering medications to patients who have seizures, who have aware, like who are aware during seizures, like focal aware seizures, and who are having clusters of focal aware seizures. It might be a good method of delivering medication. So there's other things in the pipeline too. I am most excited about the alprazolam that we just spoke about, and also about the buccal midazolam, because I know that we've had trials and it's been used in the UK for a long time, and it has been used with a good efficacy and with a lot of literature to back it. So I'm hoping that that might be something that will come up pretty soon. There are other drugs, the pro drug of the diazepam that's being tested. So essentially, we did really well in the last 3 years with getting intranasal. Now let's look and see if there's other ways of getting medications. It would be nice if we had another easier delivery system. If there was a system that could sense when the seizure is happening and auto deliver medications, that would be the dream, right? That there is a robotic way of delivering medications. Now we are starting to do that with non-medication methods, right? We've done that with VNS, we've done that now with RNS, but it would be good to see if we could try a learned algorithm to deliver medications with seizure recognition. We just spoke about vagal nerve stimulator. So the thing with vagal nerve stimulator is that it becomes so seamless after a period of time that parents forget to swipe the magnet, but it's an extra tool that you have, that you can swipe the magnet across the generator on the chest to stop the seizure. So always make sure you carry the magnet if you have a VNS placed. Last but not least, there are many different types of seizures, there are many different types of patients, and there are many different ages of patients. Most common age group for epilepsy is the school years, right? That's where we see a lot of children with epilepsy. They need to go to school. With the help of Epilepsy Foundation and the tireless work of parents, we have come up with a seizure action plan that the physician and the parent will sit down and put together, and there will be a seizure action plan that's in school detailing the type of seizure, detailing the medications that the patient currently is taking, and when to give what rescue medications. And this is now standardized and is present with is definitely with every child that we see. And if you don't have a seizure action plan, you should be asking for one. Okay. Last but not least, again, the tireless work of all these warriors here, we got a Seizure Smart School Act. This came into action last year, as I think it was right in the middle of COVID. That again, this Seizure Smart School Act requires all school personnel to be trained in seizure first aid. And if you don't know already, Aisha does a fantastic job of epilepsy education. Essentially, this requires that children who have epilepsy, it recognizes that they need to have a seizure action plan, and they will need instructions on how to manage epilepsy, and those instructions to be written down and present in school. And also, many children have medication administration to be done in school, so this also requires that medication administration can be done in school. and a form to be filled and left at school. So I think these are really important milestones as a public health initiative for patients with epilepsy, and we've I think have to look at it as a collaborative effort between the parents, the patients, and the clinicians, and as well as the school and all the healthcare providers. So essentially, um, you know, the take-home points from my talk today are: what is status epilepticus? When do we start to worry and treat? The first medication that we use is a benzodiazepine. There are now different types of benzodiazepines tailored to your particular child or your particular seizure type. And to have that rescue medication on person in school and easily accessible, because seizures can happen. That's the frustrating part, is that they can happen at the most you know unfortunate times, and we need to be prepared to make sure that the seizure doesn't go into a status epilepticus by using these medications that we have available to us. um, and I think that's about the end of my talk, and I would welcome any questions. I think there may be some questions in the chat box, but
Yeah, wonderful talk. Thank you. There was a question that came up at the 6:34 minute mark in the chat box.
yeah.
From, you can take that.
Let me see. Oh yeah, I see a question from Dr. Jennifer Pearson.
Yes.
That they thought they would have to know how to check vitals. Um, no, we don't expect, the staff to take vital signs. Especially if they are in an acute care setting. Now, it depends on what is meant by a care aid and where is this care aid. Um, is this a care aid in school? If they're in school, there is no availability to take vitals, right? If they are a home health aid, then possibly if they have a pulse ox or a monitor, then that would help. But essentially, it's not necessary to take vital signs. Um, if this is a documented seizure type that the patient is having and the seizure is not stopping at the time it's supposed to stop, and you've done all the waiting and watching, I think it's time to go ahead and do the rescue medications. Respiratory depression. Yes, respiratory depression is a important side effect of benzodiazepines, but typically it's not as severe as it's meant out to be. Okay, the more, I think the danger is when we stack medications one on top of the other. A single dose of diazepam, in the correct dose for the child, does not necessarily cause respiratory arrest.
Thank
Uh,
you. Another question was, how often can we use Valtoco for clusters?
Recommended is to use Valtoco once, but what we have said is, again, clusters. If you say, if the cluster is going on for 15 minutes and you've given one dose of Valtoco, I would say wait and see if the patient comes out of it. I would give it another 15 minutes or 20 minutes to see if the patient's out of the seizure. If the patient's completely out of the seizure, observe. If the cluster returns, I would say you can give a second dose of Valtoco, but at that point, if you start to see that there is a little bit more drowsiness or sedation, I would say call EMS when you're doing it a second time, just to make sure they come in, they check the vitals, and making sure that the seizure is not ongoing after the second dose of Valtoco. Because after 2 doses of Valtoco with the clusters of seizures, if the clusters are ongoing, they will need escalation of therapy.
And Maggie's asking if the Seizure Smart School Act applies to colleges, and right now it does not. The way we wrote the law is that it's K through 12. We would love for it to extend to college. and even, private schools, of course, but right now it is public K through 12. So, and thank you, Dr. Tatachar, for the shout out. We definitely are happy to train anyone, any school, and now it is required, so we provide that training. Another question came through, what about rescue meds for the cyanotic seizures?
Excellent question. So rescue meds for cyanotic seizures, it's the same. There is no need to worry. For cyanotic seizures, however, most patients who have generalized tonic-clonic seizures or seizures with autonomic dysfunction causing cyanotic seizures usually will have respiratory or desaturations during the seizure itself. These are usually short-lived. Unless the desaturation is sustained, there really should not be a cause for worry. Most patients who have cyanotic seizures will have either a pulse ox or oxygen at home based on the severity of the desaturations during seizures, irrespective of the cyanosis, because most patients do have some lip cyanosis during seizures, which is self-limited. If the seizure continues beyond 5 minutes, first line of action is still benzodiazepines. If there is a concern of with the rescue medications, I always say call EMS as you are giving the rescue medication. Okay, so shout for help. This is the same thing that you learn in ALS for CPR. You're giving the rescue medications. This is the ninja mom. You're giving the rescue medications. You're on the phone calling EMS. Okay, so or somebody's calling EMS and you're giving the rescue medication. So yes, it's still the first line. Benzodiazepines, diazepam, diastat, depending on the age of the child. The one caveat is neonatal seizures. Okay, I just wanted to make sure we in neonatal seizures, the distribution of GABA is different. So we do not use diazepam in the first 28 days of life. We have a different way of treating. And if you had a preemie who had seizures in the NICU, you probably don't use diazepam again in the first 28 days of life. But other than that, it's still diazepam. And Dr. Jennifer said it was geared towards school. So home, yeah, school nurses, I'm not sure if school nurses have access to vital signs. I don't know if that's universal in most schools. For most part, again, it's not necessary to take vital signs. If it's something simple as to observe a child breathing and counting the respiratory rate after the administration of medication, then I would say that is okay, but then you need to know what the normal respiratory rate is to put that into perspective. So we don't expect that as a criteria.
That's a good point. If you don't have a baseline, it doesn't make any sense really to take vitals at that moment. Any other questions? That you're welcome to unmute yourself. Ask anything.
I see a question that says, is it safe to use Valtoco 2 to 4 times a week? It is safe to use it, but if you're using it 3 to 4 times a week, at that point, you don't have good control of your seizures. And I would circle back to your primary provider and say, why are we using rescue medication so often? There needs to be some change in your daily medications or your chronic medications. It may be okay when you're titrating medications or, there's an increase in seizure frequency at that point. But if you're using this on a routine 3 to 4 times a week, then obviously there needs to be some other medication change that needs to be done.
So you're most excited about the staccato in the pipeline?
Yeah, I think it's a very fascinating. We have a lot of experience from asthma. I'm going to use that as the other, big healthcare concern that we see in children. And we know that with their MDI or metered dose inhaler, they have had good effect, right, in controlling asthma attacks, right? Is that something that we can use for epilepsy? Overall, don't you think overall the societal stigma for asthma and epilepsy, if you compare them, I do feel epilepsy still has a lot more stigma in society. I mean, this may be just me, but I think that's my
Oh,
general.
you're right. No, I agree with you. I think most people on this call would agree as well, for sure. There we have,
So
definitely.
people walk around with their inhalers, but people kind of still nervous to walk around, or there's such a big deal. There's such a big deal about seizure medications or seizure rescue when compared to an asthma rescue. So I think if we can make it a little bit more easier, if we have an availability that we can do a meter dose inhaler or just a staccato release, I think that would be very helpful. And of course, the brain is very scary, right? If it's a different. I mean, I'm not saying it's very different. The asthma and the brain are two different things, but I still feel it's important to be to have that more visible in school, so it's okay to walk around with rescue.
And did you say what phase they are in the trials? Like
Phase
how
three.
close? Phase three. Okay, so that means
Hmm.
they're getting very close.
Yeah.
We could see something maybe early next year.
Yes. Because it was a small group that was doing it, I'm not sure how far along with the COVID they got, because a lot of you know attention was not on
Of course.
everything else. So
But that's a good thing to look forward to
yes,
for sure.
yes. So far, again, it's only for adults and only for those who have partial onset or photosensitive seizures. But I think if it's something that gains popularity and effectiveness in that population, we can soon bring it over to children as well.
Wonderful.
And then the one more thing I would say is, there's a lot of apps, there's a lot of help out there to track seizures. um, I do want to make it known that a single seizure does not cause brain injury. I cannot reiterate that enough. A single seizure does not cause brain injury. So if the patient has a seizure that is long, over 30 minutes, has not responded to benzodiazepines, then it's called a benzorefractory seizure. Then we're going on to second line of medications, fosphenytoin, phenobarbital in cases, Depakote, Keppra. In such situations, then yes, there is a possibility of long-term, you know, damage. But again, if it's a multiple refractory status epilepticus, a single self-sustained seizure or a brief focal seizure do not cause permanent or lasting damage to the brain.
There was one more question that came to me, but it's actually directed to you.
Mhm.
If a child frequently has unaware focal clusters that last 30 to 60 minutes despite rescue medication, what do you recommend?
30 to 60 minutes with return to baseline.
Yeah, 30, yes, return to baseline, but for very brief periods of time before the next seizure starts.
So you can use rescue medications, but again, I would go back to the fact that if this is happening, then obviously we need to adjust chronic daily medications,
Okay, thank you.
or at least figure out why this is happening, because that essentially means that their seizure is not well controlled, right?
Yeah, the is now a young adult, but very, very refractory.
Yeah. So there, just to let you know, if it's a focal seizure or refractory seizure and medications are not working, there's also surgical options. So there may be something to think about.
Yeah, thank you. Unfortunately, she's had a couple surgeries and sadly they weren't the answer, but there are new things on the horizon, hopefully.
Yes, there are definitely new things on the horizon for focal epilepsy for sure. New medications too, actually.
Thank you.
Conversation tonight. Thank you so much again. So relevant to the time of year and just I think this is an important topic regardless. But I think you gave a lot of really important messages and good reminders. And again, the seizure action plans are also available on our website. We made that part mandatory in the Seizure Smart School Act so that the child has an advocate always, and it's that paper and it's endorsed by you or whoever the treating physician is. So we find that to be a really, really important piece of the puzzle. So thank you so much for your time tonight. And
Thank you.
yeah, this is recorded, so this will live on our YouTube page. But if anyone would like to go back and look, but thank you again for being here. Thanks everyone for joining.
And thanks to all, the parents also need a shout out because having a child with epilepsy and raising a normal child is hard. Raising a child with epilepsy is definitely harder. So you guys have to take some time out for yourselves and, give yourselves a pat on the back. Okay.
I love that. What a positive, wonderful message to end on. Thank you so much.